Hello, everyone. My name is Malak Ibrahim Muhammad. I am a second-year medical student, and with me here is...
Hello everyone, my name is Hanin Faisal. I'm also a second-year medical student.
And we're very excited to give you guys this fall session. Inshallah, this will be very helpful for you guys. And we tried to cover as much as possible. Yeah, there were some things that were not mentioned in your lab notes, but they were mentioned in ours, and we still included them. So hopefully this will include everything, but please do make sure to go through your lab content as well. Don't just solely depend on this.
But we tried to put every hard used concept. Inshallah, watch this and do the lab committee, and you'll be good inshallah for the exam.
Inshallah.
So
Okay.
let's start. Okay. So first thing, what we'll be covering.
Wait, okay. Hold on. Okay. So this is the table of contents. We will start with the posterior abdominal wall, and then we'll go over the kidneys, and then the ureters and the bladder. And inshallah, we'll also cover the histology part of each one of these. And we'll have pop quizzes by the end of each one.
Okay, and after that, urethra, and then prostate, the ultrasound and radiological images, and lastly, sectional anatomy. So let's start first thing with the posterior abdominal wall. What makes up the posterior abdominal wall? First thing, the vertebra. We don't have just one part of the vertebra. There are many different types of vertebra, starting with the cervical vertebra, and then we're going to have the thoracic, and then the lumbar, and then sacral vertebra. Which one is in the posterior abdominal wall? It's the lumbar vertebra. And we have 5 lumbar vertebrae. So posterior abdominal wall is made up of those 5 lumbar vertebrae and some muscles that I'll be going over. But first, let's talk about the vertebra. How can you, because they might give you, like, for example, 3 different vertebrae, cervical and thoracic and lumbar, and ask you, point out which one is the lumbar vertebra. So how can you know that? There are some key points that you have to know. That the lumbar vertebra is kidney-shaped. It has a short spinous process, and there's facets on the transverse process are absent. Let me explain this on a picture. So first thing, you can look here that it looks like a kidney shape. So the lumbar vertebra, first thing, it looks like a kidney shape. Another thing, this is the spinous process. Comparing it to the thoracic and cervical, it's a short spinous process. And this is the transverse process, and you can see it does not have facets. Those are the facets. Those facets are not found on your transverse process. So if they ask you, this is a lumbar vertebra, give me 3 reasons why this is a lumbar. The first thing you're going to say that it's a kidney shaped, it looks like a kidney. Second thing, you'll say that the spinous process is short. And lastly, that there is no facets on the transverse process. Okay, now for the muscles. First thing, we start here with the diaphragm. And then you're going to have this muscle, which is a really important muscle, which is the psoas major muscle. And then you're going to have the one that looks similar to it, but smaller. If the bigger one is called major, then the smaller one is called minor. So psoas major and psoas minor. And then lateral to this psoas major is also here, but it's removed just to see the muscle behind it. It's called the quadratus lumborum. From why is it named quadratus? You can think of it because of the shape. It looks like a quadrilateral. So this is the quadratus lumborum, sorry. And the one that's most lateral, which is here the outside, it's called the transverse abdominis. And lastly, the last muscle is the iliacus. How can you remember it? It's from its position. That's why anatomy is really nice and like muscles, because you can link the position with the muscle. This muscle is found in the iliac fossa, so it's going to be called iliacus. So this is the iliacus. The psoas major and iliacus can join together to form a muscle. Anyone knows what's the muscle? Try to connect the 2 names, iliacus and psoas major.
Iliopsoas?
Exactly, iliopsoas. And do you know where does this iliopsoas attach? You can look at it here.
Lesser trochanter of the femur.
Perfect, yes. The lesser trochanter of the femur. This is the femur. It has the greater trochanter or the lesser trochanter. Both of them, they will join together and insert in the lesser trochanter. Okay, now let's take each muscle by its own. For every muscle, you have to know 2 things. Its nerve supply and its action. Let's start with this one, which is the quadratus lumborum. We said the quadratus lumborum is lateral to your psoas major. This is the psoas major and this is lateral. As you go like this is lateral, and as you come to the middle, this is medial. So this is lateral. And what's the nerve supply? It's the upper 4 lumbar ventral rami. You don't have to understand it because it's part of the lumbar plexus, but just know that the 4 lumbar vertebrae, out of them, some nerves will go out, and those 4 are the ones that will supply your quadratus lumborum. Now, what its action? It's the lateral flexion of the vertebral column. How can you remember this? We said in the quadratus lumborum is laterally. So remember that since it's lateral, it will do the lateral flexion of lumbar vertebral column. What is the lateral flexion? Is basically bending. So when you bend to the side like this, what helps in bending, which is the lateral flexion, is the quadratus lumborum. After that, which is the most important muscle, that if they get you anything in OSPE, either on a cadaver or anything, because you can easily identify it, it will be the psoas major muscle. For the psoas major, here it is. This is the psoas major. The one on top of it is the psoas minor. Okay, what's the nerve supply? It also has the same nerve supply as the quadratus lumborum, which is the ventral rami, the L2 to L4. However, it also has the femoral nerve. So it's important to memorize which one is the differentiating one. So psoas major is femoral nerve. What is its action? It also does the bending, which is the lateral flexion. However, what's the most important function of psoas major? It's the flexion of the hip joint. And this came previously in multiple exams. They show you the psoas major and they ask you what's its nerve supply and what's its action. So it's very important to know that the action of this psoas major is the flexion of the hip joint. Now let's go with iliacus, which we said is found in the iliac fossa. The iliacus is also the nerve supply is femoral, and the action is flexion of the hip joint. So it's basically the same as psoas major. Psoas major was innervated by femoral nerve, and its action was also flexion of the hip joint. Now this muscle, which is the diaphragm, and I think we all know the function of the diaphragm. Can anyone remind me what's the function of the diaphragm? Respiration, yes, exactly. It's for breathing. And what's the nerve supply of the diaphragm? Phrenic nerve. Okay, now we're going to talk about the aorta. The aorta has 3 parts. It has the ascending part, and then the arch, and the descending part. The descending part is divided into 2 parts, the abdominal or thoracic. How do you know that we started the abdominal or thoracic? When you see it's changed into, when it passes through the diaphragm. When it passes through the diaphragm, we start with the abdominal. Okay, this abdominal aorta is going to bifurcate into 2 things, the right common iliac and the left common iliac. Make sure to know where is right and where is left. This one is going to be your right and this one is going to be your left. Because if in the exam they point for you this one and tell you, for example, what is this? You can't just say common iliac artery. You have to specify, is it right or left to get the full marks. So as we said, this is the aorta. It's going to divide into the right common iliac and the left common iliac. And it's very important to know at what level it divides. It will divide at the level of L4. And this is really, really important. Yani, I'm pretty sure you're going to get a question either for this one or the inferior vena cava. This one is at L4. So this is the abdominal aorta. It will divide into the right common iliac and the left common iliac. Okay. Now, out of this abdominal aorta, some blood vessels will, like there's branches from this abdominal aorta. And those branches, they're divided into like 3 main groups. The first group will be the unpaired part. And unpaired, what do I mean by unpaired? Meaning like there's only one. For example, if we think of a renal artery, since we have 2 kidneys, it does not make sense to have one artery supplying 2 kidneys because they're in 2 different locations, right and left. So you're gonna have 2 different arteries, the right renal artery or the left renal artery. However, this means that it's paired because there's 2. There's ones that are unpaired. And what are those unpaired? You're gonna have the celiac trunk, superior mesenteric artery, and inferior mesenteric artery. It's very, very, very important to know the level of the vertebra because this is guaranteed a question that they're gonna ask you. This you can see here, this is the celiac trunk. It's at level T12. And then this is superior mesenteric artery. It's the level of L1. And here lastly, the inferior mesenteric artery, level of L3. So again, let's recap. This is the aorta. It's going to bifurcate into the right common iliac or left common iliac. At what level? Yep, exactly, at L4. it will bifurcate at L4 into the right common iliac and the left common iliac. And we said the unpaired ones are what? The celiac trunk, which is at T12, the superior mesenteric artery, which is at L1, and the inferior mesenteric artery, which is at L3. Now let's go to the paired ones. Okay. For the paired ones, as I said, paired why? Because they're usually like two organs, one on the right side and one on the left side. So let's start with the renal. This is the kidney, and basically this is the renal artery. At what level is it? It's at level L2. Some sources say L1 or some sources say L2. However, I followed Dr. Elina's slides. She mentioned L2. So if it comes in the exam, say that it's L2. And above the kidney, there is the suprarenal gland. And again, of course, there should be an artery supplying the suprarenal gland. And this suprarenal is going to be supplied by L1. The level is at L1. The artery level is at L1. And then you're going to have the gonadal, which is basically the testicular or ovarian, testicular in males and ovarians in females. And at what level is L3? Those are not really important. The most important one is the renal artery, which is at L2, and the unpaired ones. Okay, now there is the ones that are parietal visceral, which are the posterior ones. So we said this is the anterior ones because you can see them. And the one before that, which is this slide, it was the lateral one because they come laterally. And now posterior, which you cannot see. And it's a bit low yield, but just know what are the arteries that are found posterior. You have the inferior phrenic artery, lumbar arteries, L1 to L4, subcostal meaning like under your last rib, which is rib 12, and medial sacral artery. Those, I've never seen a question in telling you, for example, at what level. It's mainly the ones that I mentioned before and I stressed on. Now, can someone try and help me to label this? I want someone to open their mic and try. Who wants to try?
I'll go ahead.
But what's number 1?
Abdominal aorta.
Okay, and then the abdominal aorta, this level, what is it?
L4.
Perfect. And what is this artery?
This is the left common iliac.
Perfect. And this one?
Right common iliac.
Okay. I did not mention this, but do you know what's number 4 and what's number 5?
4 is the internal iliac and 5 is the external. Right.
Perfect. So the common iliac, from its name, it's common. Yani it still did not divide into two things. There is the internal one, which is going internally, and another one, which is the externally. So what do you think the third one is from its position and what it covers? What do you think it is?
Third one.
Yeah, this one, number 3. Look what does it surround, like the arteries surround what?
The lumbar vertebra.
Exactly. So what's the arteries?
Lumbar.
Perfect. Thank you so much. So again, a recap. This is the aorta. It's going to divide into the common iliac. This is the left and this is the right. And then it divides into the internal and external. And this is the lumbar. Okay, now we finished the aorta part. Now we're going to talk about the inferior vena cava. For the inferior vena cava, it's the same thing. Just switch everything into a vein. You're going to have here the left common iliac vein and here the right common iliac vein. They will join together at a level, and this level is L5. This is also a really important level to memorize. So the aorta, we said they will bifurcate at L4, and the vein, they're going to join together at L5. Okay, now different veins, and they have to drain somewhere. Let's start first thing with the gonadal veins. You're going to have the left and the right gonadal veins. Those are the left. This is the left gonadal vein. And this is the right gonadal vein. Looking at it, look at the right, you'll see that it drains here, which it drains in the inferior vena cava. While if you look at the left, it will drain into the left renal vein, and then the left renal vein will drain into the inferior vena cava. And this is really, really important. 100% they ask you this, because they usually like to ask about the things that are not common, or like the things that stand out. And this definitely stands out because any vein should drain into the inferior vena cava. However, the left one, the left gonadal vein, will drain into your left renal, and then the left renal will drain into the inferior vena cava. Okay, now we finished the gonadal veins. Now the suprarenal veins. They have the same rule. The right suprarenal It's not shown here, but the right suprarenal is going to drain into the inferior vena cava, and the left suprarenal will drain. It's like this, yeah. The left suprarenal will drain into the left renal vein and then drain into the inferior vena cava. So the two exceptions are the left suprarenal vein and the left gonadal. They will not directly drain into the inferior vena cava. They will drain into the vein, renal vein, and then drain into the inferior vena cava. Okay, and why is this important? Like, why should you know this? Because usually in OSPE, yes, they'll ask you, for example, where does this drain? And they might ask you, for example, what's the clinical significance of this? And you have to know this, that the left gonadal vein, which is basically in the left gonadal or the left testicular vein, there's something called the paniform plexus. So we said it will drain into the left renal vein and then to the inferior vena cava. And by this mechanism, it's most commonly, it's the most often located part where the varicocele happens. What is varicocele? It's when this pampiform plexus gets enlarged. If we look at it here, this is basically the pampiform plexus, which is the left gonadal vein. And since the left drains into the left renal vein and then the inferior vena cava, it's most likely that the left part is the one that's going to get enlarged, which is the varicocele. Okay. Lastly, we'll end up with the nerves. Oh, this picture is really important because I remember in our exam, he got us the same exact photo. So, let's start. So the first nerve you have to know is this one, which is the subcostal nerve, which is below the last rib, which is rib 12. And then you're going to have this one, which is the L1. This L1 divides into two, iliohypogastric and ilioinguinal. However, in the exam, you can just say L1, not specify iliohypogastric or ilioinguinal because it's a bit difficult to know which one is iliohypogastric or which one is ilioinguinal. But if he gives you the same exact picture, then you should have memorized it. In number 3 here is the iliohypogastric, or number 4 is the ilioinguinal. However, if he just points at number 2, just say L1 to be on the safe side. And even if you say iliohypogastric or ilioinguinal, put in between parentheses, it's L1. طب. Okay, let's talk about number 7. What muscle is this? Can someone guess what muscle is this? Let me see the chat. Yes, exactly. Yes, it's psoas. It's psoas major. This nerve is basically anterior to the psoas major. And what's the nerve that goes anterior to the psoas major? It's genitofemoral nerve. So genitofemoral is the one that's going to be in front of psoas major. So if they give you a cadaver and you can see the psoas major and مثلا they point on the nerve that's going above the psoas major or like anterior to it, you know that this is directly the genitofemoral nerve. Okay, and let's do this one because it's the easier one. Number 6, it's the femoral nerve. How do you know that this is femoral nerve? Because it's the thickest nerve. So if they point on a thick nerve, it's the femoral. And if they point on a nerve that's anterior to the psoas major, it's the genitofemoral. Okay, and if we said this is subcostal and this is the L1. Okay, what else did we miss? Okay, this one. The most lateral one here, the most lateral one is the lateral cutaneous. From its name, lateral cutaneous. But lateral cutaneous is the most lateral one. So we said this is lateral cutaneous. This is the femoral because it's the thickest. And this is the genitofemoral. The last nerve you have to know is the obturator nerve. Yes, obturator nerve, which is here. This obturator nerve is more medially compared to the other nerves. So if they point on a nerve that's more medially, that's obturator. If they point on a nerve that's in front of the psoas major, that's genitofemoral. If they point on the thickest nerve, that's femoral. And if they point on the most lateral one, it's going to be the lateral cutaneous. And if they point here on top, here L1, it will most probably be here, sorry. Yeah, if it points here, it's L1. Okay. And whatever I said is written down here in words. Okay, lastly, you have to know it's what nerve innervates what. Dr. Elena in her slides included more. I'm not sure if you have to know them or not. However, I included the most high yield ones and the ones I found questions on. So the femoral one, it will innervate your anterior thigh and the medial surface of the leg. The lateral cutaneous nerve of the thigh, from its name, it's lateral nerve of the thigh. That will innervate the thigh. Which part of the thigh? The anterior and lateral. And then you're going to have the obturator. We said the obturator, if you remember here, is the most medially. with common sense, and you can link it that way, and the obturator is the one that's going to innervate the skin of the medial thigh. So again, the anterior thigh will be the femoral, and the lateral cutaneous nerve of the thigh is going to be will innervate the anterior and lateral, and obturator will innervate the medial aspect of the thigh. This is pure memorization that you have to memorize. The most one that I found questions on is femoral. Okay, now let's solve some questions. I'll give you like 30 seconds for each question. Okay, I'm getting A. Perfect. It is A, because this one is the ilioinguinal. Can someone tell me what's B? This one. Yes, lateral. And can someone tell me what's C? Perfect, femoral, inshallah. Okay, now let's go with the next question. Oops. I hope you did not see this. What muscle is this? This one. And its action. Okay, everyone said it correct. So it's major flexion of the hip. Okay, someone said lateral flexion of the lumbar spine. Yes, it's correct, but this is not its main action, because lateral flexion can be also quadratus lumborum. So in the exam, write the main one, which is basically the hip flexion. Okay, now let's go to the next one. Here, identify A and B and mention their levels. Okay, yes, everyone is getting it correct. Perfect, yes. So basically A is the right renal artery. Some people wrote right, they just wrote renal artery. Better say right, because I'm not sure. I think, yeah, they're شوية strict in marking in between right and left, so right. And yes, it's L2. Well, this is the inferior mesenteric artery. صح. And يلا, this one. What's A and what's B? And tell me what's the clinical significance of C. So to get the clinical significance of C, you have to know أصلا what's C and then know it. Okay, C, they don't want what artery it is or vein it is. They want you to tell them what's the significance. What's the clinical significance? Okay, yeah, perfect. Everyone got it. Oops, sorry. So A is going to be the left renal vein, B is the ureter, and C is the varicocele. Why? Because it's the left gonadal vein, and we said the left gonadal drains in the left renal vein, and then from the left renal vein into the inferior vena cava. Okay, and the last question, what's X and what's X and what's Y, and what's the spinal level of X? And عادي, say what's the spinal level of Y. Okay, specify, is it an artery or a vein? Perfect. Okay, perfect. X is the common iliac artery, and Y is the common iliac vein. And B, which is the question asked for the spinal level of X, it's L4, because we said the bifurcation happens at L4, and here the bifurcation happens at not bifurcation, sorry, the joining happens at L5. And with that, one more question. Which one is the lumbar vertebra and why? Okay, some people are saying 2, and some people are saying 3. I'm sorry, guys. It's the third one, and because, as you said, the kidney shaped and the short spinous process. Yeah, sorry for the confusion here. Yes, it's the third one. And with that, the posterior abdominal wall is done, and kidney, Malak will give it to you guys.
Hello, it's my turn now. Okay, so we'll be covering the kidney, inshallah. Now, we'll start with the basics of the kidney. So what is the kidney? The kidneys are basically just retroperitoneal organs. They are located, when we say retroperitoneal, we mean that is behind the peritoneum, which is basically the sheath that covers your abdominal organs. And the kidney is one of the retroperitoneal organs, so it's located behind it. Now, another thing that you need to know is that they're placed obliquely and that they're located between the T12 and the L3 vertebra. This is very, very important. You guys need to be able to know which levels the kidneys would extend from. Okay, now they are surrounded by 3 abdominal muscles. These abdominal muscles are very important to know as well. First, you have the psoas major. So you can see I labeled it, I highlighted with yellow for you guys here. The medial aspect of the psoas major is what surrounds the kidney. You also have the quadratus lumborum, but the lateral aspect of the quadratus lumborum, and you also have transverse abdominis. Okay, now the kidney basics, we're also going to be talking about the position of the kidneys. So the right kidney is actually a little lower than the left kidney. It's 2 to 3 centimeters below because the liver pushes on it, so it pushes it down 2 to 3 centimeters. And the left kidney, it is protected posteriorly by the 11th and the 12th floating rib. As you can see here, your left kidney, it is protected from behind posteriorly by the 12th rib and the 11th rib. Now, the right kidney, as we said, because it's lower, it's pushed by the liver. It's only protected by the 12th rib posteriorly. Now, I color-coded the left kidney with blue and the right kidney with green. You guys will know later why, but just keep that in mind. Now, the kidneys, they are surrounded by 3 layers of tissue from deep to superficial. First thing, you have the fibrous renal capsule, which is located on the outside over here. Sorry. The fibrous renal capsule is the capsule that's on the inside. Now, this is very, very connected to the kidney. It almost blends into it, and this is what causes the kidney to have its characteristic shape that we're all used to, the being kidney shaped. Now, this it's labeled as 1. You guys can see over here. Hold on. Sorry. Okay. You guys can see over here. This is the renal capsule, and it's the deepest layer. And then you have the perinephric fat, which is the layer in between the outermost layer and the deepest layer, which is the capsule. The perinephric fat, basically, it's just fat, and it acts as a cushion in order to protect your kidneys. And it's immediately outside the renal capsule. Now, your renal fascia, it is a thin layer of dense connective tissue that's located on the complete outermost layer. And this anchors the kidney to the posterior abdominal wall, so it holds it in place so it doesn't, fall down. Okay. Now, this is why I color-coded them, so that they can stick in your head better in the exam. This is very important. They always like to ask a question about the external structures, like that cover the kidneys. So I made a mnemonic for you guys. Hopefully it'll help. The right kidney, as we said, it's green, so remember it as green. When you're in the exam, you remember that it was labeled as green. And the left kidney is color-coded with blue. So the right kidney, the mnemonic is really lazy dudes, relax and sleep. Now, this is from the superior to inferior order. So you will start superiorly. R for right suprarenal gland. So it's covered superiorly by the right suprarenal gland. And then you have the liver over here. And then this is all covering it anteriorly. Like the surface of the kidney is covered by these structures. Then you have the duodenum over here. And then you have the right colic flexure. And then you have the small intestine. This is pretty easy. You just have to memorize it. And inshallah, and this mnemonic will help you remember it. Okay. Now, the left kidney, this is also superior to inferiorly. Sally's sister sings perfect little dance jingles. And here you start suprarenal gland again. Superiorly, it's covered by the suprarenal gland. And then you have the stomach over here. You have your spleen on the side over here. And then you have your pancreas. And then you have the left colic flexure, and then the descending colon and the jejunum. Okay? All right. Now, this concept is extremely important, and I tell you this because they usually like to ask, they give you a kidney and they ask you if it's a right or left kidney, and this is why it's important to know how the structures that enter the hilum are in order, yani what order they're in. So the renal hilum is basically located on the medial border of the kidneys, and this is at level L1. And the structures passing through this hilum, the mnemonic for it is VAP. So this is from anterior to posterior. Anterior to posterior, please remember this. So you will start with the renal vein. So this is the most anterior structure that enters the hilum. Then you have your renal artery, which is in between, and then you have your renal pelvis. Now, the renal pelvis leads to the ureter. I need you guys to know that the pelvis is actually more interiorly, and it's more towards the inside. But just remember ureter for this one. This is just for the sake of the mnemonic, so it's easier to remember. But it's actually ureter. So renal vein, artery, and then ureter. Okay, now the internal structures of the kidney. The order, technically, the kidneys are divided into three main internal structures. You have the cortex. Hold on. Okay, so you have the cortex, which is the most outermost layer, and then you have the medulla, which is towards the inside, over here it's towards the middle, and then you have the renal pelvis over here. Now the cortex, it's the outermost layer, it's lighter in color, and this contains the renal columns. Now your renal columns over here, okay, so your cortex is over here on the outside. Your renal columns are basically just the cortex. The cortex goes and it invaginates itself in between the renal pyramids, which we're going to discuss in a second. But the renal pyramids are a part of the medulla, but they're separated and they are made up into pyramids because of the renal columns. Now, the renal columns are part of the cortex, so the cortex is on the outside, but it invaginates into the middle of the kidney towards the center of it. It invaginates inside in order to form these renal pyramids, yeah. So as we said, it's the outer layer and it's lighter in color. It contains the renal columns that extend inside and separate the renal pyramids. And each renal pyramid has its corresponding renal cortex. So you have, this is your renal pyramid, okay, which is just the medulla, okay? And then you have the cortex, the part of the cortex that's outside, plus the renal pyramid gives you the renal lobe. So one renal lobe is equal to the renal pyramid, which is basically the medulla, and its corresponding cortex on the outside. Now your medulla, it is the inner region, and it is darker in color, much darker in color compared to the cortex. And it is made up of 7 to 18 renal pyramids, as I told you guys over here. And these are the ones that are separated by the... Can someone answer me in chat? What are the renal pyramids separated by? Yes, renal columns. So the renal columns, as we said, it's part of the cortex, invaginates inside, and it gives you the renal pyramids. Now, these renal pyramids then become minor calyces, which we're going to discuss in a second. But just know that the renal pyramid, at its tip, you have the tip of it is just called the renal papilla. And that's basically just the apex of the renal pyramid. And this then becomes the minor calyx. Okay, now the third main internal structure is your renal pelvis, which then would make up your ureter later on. Your renal pelvis is basically a funnel-shaped area that collects the urine, and it's made up of two main structures, the minor calyces and the major calyces. Now, the minor ones, they collect urine directly from the renal papilla, which, as we said, is the apex of each renal pyramid. So each renal pyramid becomes a minor calyx, and then this collects the urine directly from the renal papilla and it merges to become a major calyx. So a major calyx is basically just made up of minor calyces, and a minor calyx is formed by the renal papilla or the apex of the renal pyramid. Okay, now the major calyces then they collect the urine and they form 2-3 major calyces, and then they merge to form your renal pelvis. This renal pelvis, which is over here, I have it in green. Your renal pelvis then becomes the ureter. Is this clear? Do you guys have any questions? Is it all clear? Okay. So just to recap, it goes from your renal papilla, which is the apex of your urine. When I say it goes, I'm referring to the urine. So the urine moves from the renal papilla, which is the apex of the renal pyramid. It moves from the renal papilla and it goes to the minor calyx. The minor calyx becomes a major calyx, and then this becomes the renal pelvis, giving you the ureter, which then goes into the bladder, drains into the bladder. Okay. So can you guys please leave a 1 to 3 for me? If anyone wants to unmute their mic, they can, or you can answer in chat. Guys, does anyone want to answer this? Yes. Okay, any other answers? I'll give you guys like 30 more seconds. Okay. Okay, I got a bunch of answers. All of you guys got it correct. Yes, good job. Okay. So one is your renal capsule, which is basically what merges into, it's a capsule that covers the kidney and is directly attached to it, and it's what causes the characteristic shape of the kidneys. And then you have the, what's it called, the perinephric fat, which directly covers the capsule, and this is responsible for the cushioning of your kidneys. And then you have the renal fascia, which is responsible for holding the kidneys in place, so the posterior abdominal wall. Someone? Yeah, 4 is the perinephric fat. Good job. Okay, before we move on, does anyone have any questions? One thing that I want to emphasize on, hold on. Actually, yeah, answer this question first before I go back to that. Okay, good job, guys. You answered the first one. Can you answer B as well? It's not, name all the muscles that are posterior to this organ. Yes, good job. You're missing one. Yes, good job. Okay. I'll give you guys like 20 more seconds before I move on. Okay. So you guys are right. The mnemonic for this is VAP. So renal vein, renal artery, and renal pelvis, which then becomes the ureter. So you have the renal vein, renal artery, and the ureter. And then the second part is what is posterior to this organ. You have the suis major, the quadratus lumborum, and the transverse abdominis muscles. Now, I didn't really mention why this is very important. As I said, they will get you guys a kidney, be it left or right, and they will ask you, is this a right kidney or a left kidney? And this is how you can differentiate whether it's a right kidney or a left kidney. As we said, the hilum is located towards the medial side. So the first thing that you want to do is look at the kidney and position it in a way in which the hilum is facing medially. Okay, that's the first thing you want to do. Second thing you want to do is you want to look at the structures that enter the hilum, which are your vein, the artery, and the ureter. And this is I got a message, but it disappeared. Can you send your question again? Okay. So as I said, it would be positioned in a way in which the most anterior structure would be your vein, and then the artery, and then the ureter is the most posterior one. And this is why it's very important to know this in order to be able to differentiate whether this is a right kidney or a left kidney. Can someone tell me whether this is a right kidney or a left kidney? Someone kind of already answered this. Yes, you're right. You're all right. It is a right kidney because, as we said, the most anterior structure would be your vein, then your artery, and then your ureter, all the way in the back. And as you can see here, the hilum is already positioned medially, so you don't really need to reposition that. Is that clear? Can I move on? Okay, I'll be moving on. Now, I'm kind of done for my part. One thing that I want to mention is that we're supposed to cover the histology. Inshallah, I'll cover it in the end of the past session. So for now, we'll just go through the rest of them, and then we'll come back to the kidney histology in the end, inshallah.
Okay, and so now for my part, which is going to be about the ureter. Okay, so as Malak described, that this is the kidney, and then this is the pelvis, and from the pelvis, you're gonna have the ureter. What is the ureter? Like, what's the function of the ureter? Because we said in everything, in every structure, you have to know the function, location, and if there's anything special. So for ureter, it's basically some tubules that are going to connect from your kidney to your bladder. And what are they transporting? They're transporting urine. So they're going to transport the urine from the kidney to the bladder. Simple and easy. So for example, if they give you any histo slide about the ureter and they ask you what's the about the ureter and they ask you what's the function, you're just going to say transport the urine from the renal pelvis into the bladder. Okay, now for the ureter. Yes, it's a tube. However, this tube is like 3 different sections. We have this section, which is called the abdominal ureter. And then when you start seeing the pelvis, this part of the ureter will be called the pelvic ureter. And then when it starts to enter into the bladder, it's going to be called intravesical ureter. Why is it called intravesical? Because another name for vesicle is bladder. So this part of the ureter is the intravesical, this part is the pelvic, and this part is the abdominal. However, if they point for you in the exam the ureter, you can just say ureter. Okay. And now the ureter has 3 sites of narrowing. This is very important to know. Okay, so you can see that here's the kidney, and this is the pelvis, and the pelvis is going to change here into the ureter. So the part where the pelvis changes into the ureter, it's called the uretero-pelvic junction. So the ureter is not just one tube; it has a bit of narrowing in like 3 different narrowings. The first narrowing is when this pelvis changes into the ureter. This is your first narrowing. The second narrowing is at the pelvic brim, which is the part where this common iliac divides into the internal and the external iliac. So at this point where it divides into the internal and the external iliac, This is another point of constriction. And the last point of constriction is called uterovesical. Uterovesical, we divide the name. Always try to divide the name to understand. Uterovesical, يعني ureter, and the vesicle, which we said another word for bladder is vesicle. Another word for the urinary bladder is the vesicle. So here is another constriction. So in total, 3 constrictions. Ureteropelvic, from the pelvis changing into the ureter. The one where the pelvic brim, where the common iliac divides into internal and external. And lastly, the ureterovesical, which is when it enters to the bladder. Anyone knows what's the importance of these constrictions? Anyone can guess what's the importance of those constrictions? Yes, perfect, mashallah. It's the most common site for the renal colic, which is the renal stones. Okay. Now it's very important to know the pain of this renal colic. Wait a minute. I don't know why the images. 1 second. The images are not showing. 1 second. Guys, can you see the images? Okay, I'll explain وبعدين I can go back to it. For the pain of the renal colic, it's basically from lowen to groin. Where is lowen? It's the posterior part. And what's groin is basically the genital organs. But the pain is always from lowen to groin. And then there's 3 different parts, as we said, of the ureter. We have the abdominal part, and then we're gonna have the pelvic part, and lastly, you're gonna have the intravesical, the abdominal, وبعدين the pelvic part, وبعدين the last one, which is vesical part. Okay. Each one of them, if the stone was in this position, the pain is going to be referred to this area, which is T10 L1. You have to memorize it because they might مثلا put for you the stone at a part and they're going to ask you the pain will be referred into what segments. So if the stone was at the kidney or the renal pelvis, it will be at T10 to L1. If the stone is at the abdominal ureter, it's going to be from T11 to L2. And if it's at the pelvic ureter, it's going to be from L1 to L2. We'll finish this, and I'll get back and I'll get the picture for you guys. Okay, now the blood supply. So we're going to start with the abdominal ureter. Before telling you guys, let's try to see it here and guess. Okay, so this is the abdominal ureter. You can see that this is the renal artery, and you can see the renal artery is sending some branches that will supply this ureter. Here is the gonadal artery. You can see also it's sending some branches to supply the ureter. And here is the aorta. Direct branches from the aorta is supplying the ureter. And here also, you can see that the ureter can be supplied by the common iliac and the internal iliac. So from the picture, we can now, let's see what I wrote here. The proximal end is going to be the branches of the renal artery, because as you can see here. In the exam, if you forgot, try to remember what we said and try to remember the picture. There's branches from the renal artery, so that's one. It will be supplied by the branches of the renal artery. And then try to remember this branch, which is the gonadal artery. That's another one. And directly from the aorta, it can supply the ureter. That's the third one. And lastly, the common iliac and the internal iliac can also supply the ureter. This is the abdominal ureter. Now we're going to talk about the pelvic ureter, which is in the pelvis. The one that's in the pelvis is going to be supplied with the same blood supply of the vesicle, which is the bladder. So you're going to have superior vesicle, inferior vesicle. Okay, but here there's a difference. You have to know, is this case, in this case, is it a man or female? Because in the exam, they can tell you what's the blood supply of the pelvic ureter, and they're going to specify for you if it's a male or a female. Because I remember we got this in our exam. For the male, it's going to be the superior vesicle and inferior. For the females, it's going to be superior vesicle and vaginal artery. This is very, very important to know. They might ask you, what's the difference between the blood supply of the pelvic ureter for the man and the female? You're going to say that here there is the vaginal artery. And in both of them, you're going to have the superior vesicle. Okay. For venous drainage, always if you memorize the arterial part, the venous drainage would be really easy because it's corresponding to that part. And they're at the end, all of them, they're going to drain into the internal iliac vein. And this internal iliac will go to the common iliac vein and then inferior vena cava. Okay. Now we're going to start with the histology part. 1 second. Interior iliac artery. 1 second. Someone said I'm talking here about the venous drainage. The venous drainage, you talk about veins. It will drain into the internal iliac vein, not the artery. Yes, okay. Okay, now the histology part. What we try to do in this PAL, that for each organ, we put for you the histology part and the anatomy part instead of putting all the histology at the end, because it's easier like this to connect the anatomy and the histo and so on. We start with the ureter. This is 100% in the exam, like I'm pretty sure. They're going to give you this picture and they're going to tell you what is this. From the picture, from seeing this lumen that looks like a star shape, this is the ureter. So the first question they're going to ask you, what is the structure? This is the ureter. They might ask you, what's the function? Which is easy. The ureter gets the urine from the pelvis, which is pelvis of the renal kidney, into the bladder. So now you're done with the structure, you identified it, and you did the function. Okay. Now for the structures, we're going to talk about 3 things: the mucosa, the muscularis, and the last thing, which is the adventitia. Let's start with the mucosa. Okay. The mucosa is basically 2 parts. You're going to talk about the epithelium, like what type of epithelium is this, and you're going to talk about the lamina propria. Let's start with the epithelium. The epithelium of the ureter is basically transitional epithelium. You have many different types of epithelium: squamous, cuboidal, columnar, and then it can either be simple or stratified and so on. For the ureter, it's transitional epithelium. Another name for transitional epithelium is urothelium. So it can either be called transitional epithelium or urothelium. The ureter can either be a transitional epithelium or stratified cuboid-like epithelium. However, if they get it to you in the exam, always say transitional epithelium or urothelium, but I always like to say transitional epithelium. And this is, okay, so T and F is the mucosa. So T and F is the mucosa. T is the epithelium part, which is, we said, is the transition epithelium. And F is the lamina propria. Why did I write it with F? Because the lamina propria has fibroelastic connective tissue. Lamina propria has connective tissue, and you have many different types of connective tissues. The one that's going to be found here is the fibroelastic. Okay, we're done now with the mucosa, which is basically the epithelium and the lamina propria. Now we're going to talk about the muscularis, which is, from its name, muscularis is the area which has the muscles. The ureter, if you take a section from the proximal 2/3, it's different than taking a section from the distal third. Let's talk first thing about the proximal 2/3. It's going to have inner longitudinal and outer circular. Simple as that. And then if you cut it from down, it's going to have 3 layers. It's going to be the inner longitudinal, outer circular, outermost longitudinal. They won't ask you to identify it here because it's not visible. However, in different structures, if it's visible, she'll label it for you and you'll see it along the way now. But here, just know that the proximal is LC, or the distal is LCL. Inner longitudinal, outer circular, outermost. You always start with the inner and then you go outer. So the proximal is going to be the inner longitudinal and then outer circular for the proximal part. For the distal part, it's going to be inner longitudinal, then outer circular, and then the outermost, which is going to be the longitudinal. Lastly, it's the adventitia, which is basically just connective tissue and fat. Okay, we're basically done with ureter. It's just a simple structure, but actually, like, you can guarantee a lot of questions from it, like the renal colic one, the constrictions, and the histology part. And this is one of the histology questions. They're asking you which of the histological layers is responsible for agonizing painful contractions to force a kidney stone out. Think what part should do this. Okay, I'm getting different answers. Yes. But most of you said the correct answer, and it's C. Because the C is what part is the muscularis layer. The muscularis has the muscles, and the muscles are the ones that I need to contract to move the stone. So basically, it's the muscularis layer, which is C. A is the transitional epithelium, which is the mucosa. B is basically the lamina propria, which is the fibroelastic connective tissue. Now, name an artery that supplies this area of ureter part 4, and what is the epithelium? So here, part 4 of the ureter. What's the epithelium of ureter in general? And what's the artery that's going to supply this part? So this is 2 questions. And always in OSPE, they ask you 2 questions. And most of the times. Yeah, I'll give you like 20 seconds. For the artery, look, this ureter is close to what? Because we said the ureter can get supplied by many different parts. Look at this part and think. I give you a hint. Okay, yes, you got it correct. Perfect. It's the internal iliac and transition epithelium. It does not mean that the internal iliac is the only artery that's going to supply the ureter. It's going to be supplied by many different arteries. However, the part they showed us is the one that's going to be closer to the internal iliac. And the epithelium is transition epithelium at any place. Here, there. The epithelium is always the same as the transitional epithelium. Okay, now an X-ray. They're telling you what is this junction, and what is this junction, and what's their significance, their clinical significance. And by the way, guys, all those questions are from previous finals. Yeah, no, like they're simple questions, alhamdulillah. Yes, someone asked if you have to mention if it's the right or a left internal iliac. Yes, always mention if it's right or left to gain the full marks. Well, inshallah, if you don't mention it, they don't deduct, but always make sure to mention. Okay, I'll wait for more people to answer. Okay. Perfect, guys, you got it correct. X is the ureter pelvic. It's the part from the pelvis changes into the ureter. And Y is the ureter vesicle. And what's the clinical significance is the part where the renal stones get stuck. And with that, I'm done with the ureter.
Hi again. Hi guys. So I'll be covering the bladder inshallah, and I'll also be covering the urethra after it. So the bladder basics, again, we always like to start with the basics. So the bladder is just a hollow muscular organ, and it has a tetrahedral shape. What does this mean? You'll see in a second. But it has a tetrahedral shape, and it lies inside the pelvic cavity, and it's directly posterior to the pubic symphysis or the pubic bone. So this is your pubic symphysis, and you would have your bladder directly located behind it, posterior to it. Now, in the males, it would be anterior to the rectum, and in the females, it would be anterior to the vagina and the uterus. So this is obviously a female because you have a uterus. The bladder would be located posterior to the pubic bone and anterior to the uterus and your vagina. So this is the vagina and this is the uterus, and you can see that it is located anterior to it, but posterior to the pubic bone. Now, since the males obviously don't have a uterus, it would be located directly in front of the rectum, which is over here. So this is the rectum, and your bladder would be located right in front of the rectum. However, in females, it's located in front of the uterus and the vagina, and then behind the uterus and the vagina, you would have your rectum. Okay. So these are pictures from the cadavers. Can anyone tell me which one is a female and which one is a male, and why? Right, left is female, obviously, because the uterus is right here. But the bladder, as you can see here, the bladder is located right in front of the uterus, and the vagina would be lower down. And it's located behind the pubic symphysis over here, and behind the uterus and the vagina, you'd have your rectum. Now, this is a male, so there's no uterus. So the rectum, the bladder would be right in front of the rectum, which should be posterior to it, and the bladder is posterior to the pubic symphysis. So this is a female and this is a male. Now, we're going to be talking about the external features of the bladder. The bladder has four surfaces and it has four angles from the apex to the base. So the four surfaces are your superior surface, which is the most uppermost layer. This is the superior surface of the bladder. And then you would have the posterior. Another name for this is your base. So the superior surface is over here, the base is in the back, and from the bottom, like inferiorly, you would have two surfaces. It's not just one. So you would have the inferior lateral on the right and the inferior lateral on the sides, on the left. So you would have two on each side from the bottom, one from the back, which is the base, and a superior one. Now, the infralateral surface is the one that would be responsible for the bladder neck, the formation of the bladder neck, which is basically what gives you the urethra, and this extends from the inferior lateral surface. These are all the surfaces, and then you have the angles. You have four angles, again, from the apex to the base. The first angle is obviously the apex, which is the most pointy part in front here, apex. Now, the apex is what connects the bladder to the umbilicus in the anterior abdominal wall. Now, this is connected via the median umbilical ligament, as you can see. The apex of the bladder will be connected to the umbilicus in the anterior abdominal wall through the median umbilical ligament. What is the significance of this median umbilical ligament is that it's actually a remnant of the embryonic urachus. And the embryonic urachus is important because it's actually the structure that would connect your bladder to the embryonic sac. And this is how the baby would replenish its amniotic fluid from the urine. And so if when the baby is born, this urachus, it would be obliterated and it wouldn't exist anymore. And then you would have your medial umbilical ligament, which is the remnant of the embryonic urachus. However, if during birth, the embryonic urachus is not closed properly and it stays open, you would have a urachal fistula, which then would mean that you would have urine leakage from the umbilicus because it's still connected. It's not obliterated anymore. It's still there. So then you would have urine leakage and you would have a urachal cyst. Next, you would have the neck of the bladder, which is continuous with the urethra. Here you go. The one that comes out of the infralateral surface. So this is the bottom part, and then you have the apex from the front. This gives you the urethra. And then you would have the posterior-superior angles. So from the name, they're located posteriorly and superiorly from the sides. So you have two, one on each side, over here and over here. Someone asked a question. You can use both. They're both right. Okay. Next, you have the neck, which is continuous with the urethra, and then, we were talking about the posterior superior angles, which would be located on the sides, and this is where your ureters would enter from the kidneys, the Hanin covered. So the ureters would come from each kidney, and they would enter through these posterior superior angles. Okay. Now, the internal features of the bladder, you have the trigon of the bladder. That's the most important thing to know. They would probably ask you about the borders of the trigon. So basically, it is made up of three things. The boundaries of this trigon would be your two urethric orifices and the urethral orifice. So the urethric orifices are located on each side for each ureter coming from the kidneys. And then you have the urethral orifice, which would give you the urethra. So the trigon, it is a smooth area that doesn't have like any of these rough edges or rough mucosa, basically. It's just completely smooth. And this is why, because there's no rugae, you would have infections that would localize in this area because it's smooth. So it's easier for the infection or any microorganisms to settle in this area. And it is often, often infections happen in this part. So again, what are the boundaries of your trigon? I want someone to summarize them. Or just mention them again. Yep, two ureteric orifices and one urethric orifice. So one is for the urethra and you have two for the ureters. Okay, let me go back. Yes. So the ureteric orifices are located in the posterior superior angles, as we mentioned before, and the urethral orifice is located at the neck. We also have the bladder wall, which is composed of the detrusor smooth muscle, and this is what enables micturition, because when it contracts, you would have micturition or emptying of the bladder. Okay, now the blood supply, honestly, we did not have this for our OSPE at all. We did not take this in the lab. It was just very, very briefly mentioned. We didn't have all of this. We did take this in renal, but not in renal, in endorepro. But you guys had it in your slides for the lab, so I'm just going to mention it. The venous drainage, you have veins that correspond to the arteries, and they drain into the internal iliac vein. So these are the arteries, so we're not going to cover that. It's just as simple as you would have the same ones as the arteries. So they correspond to the arteries and they drain, all of them drain into the interior iliac vein in the end. Then you have your arterial supply, which we're going to discuss now. The bladder's arterial supply, it comes from branches of the interior iliac arteries. What are these branches? You have the superior vesical artery, you have the inferior vesical arteries, the obturator arteries, and the inferior gluteal arteries. It's a lot to remember, but honestly, I would just say know the main ones. You don't need to know, especially this part. I think this part, he could ask you a question about it. The ones in males and females. The inferior vesicular artery, which is over here, in males, it supplies the fundus and the neck of the bladder, but in females, it's not supplied, the fundus and the neck of the bladder are not supplied by the inferior vesicular artery, it's supplied by the vaginal arteries. Because as we said, the vagina was located right behind it, right? So it doesn't need to have a different artery just to supply it. So it's replaced by the vaginal arteries, which supply the posterior inferior bladder. So you have the superior vesicular arteries, you have the inferior vesicular arteries, you have the obturator arteries, and then you have the inferior gluteal arteries. That's kind of all you need to know. The venous drainage is the same, so they correspond to the arteries, and all of these drain into the interior iliac vein, whereas the arteries, all these arteries that we discussed, they branch off of the interior iliac arteries. Okay, now we're going to be talking about the bladder histology. So the bladder has 3 layers histologically, not just histologically, it has 3 layers. It has the mucosa, and this mucosa is made up of 2. It's made up of your transitional epithelium, or the urothelium, that we would also find in the ureters. And you also have the lamina propria, which is the fibroelastic connective tissue. And this is where you would find the capillaries, whereas the transitional epithelium, or the urothelium, it's actually avascular. So as you can see here, this is the transitional epithelium. Now, why would you guys need transitional epithelium in your bladder? I know it's common sense, but I just want you guys to interact a little. Yes, to the stand. So you're going to have to hold this urine. It allows for filling, exactly. So this transitional epithelium, it's actually just epithelium that's kind of contracted and it's kind of folded into each other. And this allows for the bladder to have some capacity to expand when it needs to hold urine inside. And this is why we have this transitional epithelium or urothelium. This is avascular. And then the lamina propria, it's fibroelastic. And this is the one that has the capillaries. The transitional epithelium is avascular. It doesn't have anything. Now, this transitional epithelium, it forms rugae in order to allow for more distension. Now, next, oops, sorry. Okay, next you have the muscularis layer, which is basically where the muscle would be located. What is the muscle of the bladder? Detrusor. So your detrusor muscle, it's a smooth muscle, and this smooth muscle has 3 layers. It has the inner longitudinal layer, has the outer circular, and the outermost longitudinal. Generally just memorize this. This picture is very important, by the way. If they ask you any question about the bladder, they will get you this histological picture. So make sure to know this and be very familiar with it. Now, the last one that you would have is your adventitia. So the adventitia is... Yes, we will discuss this in the next slide when the rugae disappear. Just give me a second. Now, the bladder has an adventitia, and this adventitia is formed because the bladder is an intraperitoneal organ, unlike the kidneys. So the kidneys, they're retroperitoneal, so they're located behind the peritoneum and they don't have an outer, the peritoneum is not covering it. However, with the bladder, the peritoneum is actually covering the bladder, so that's why it has an adventitia, since it's an intraperitoneal organ. Now, the adventitia, it is responsible for the reservoir of urine, so it allows for the distension for the urine to have a reservoir. And then it's also responsible for the contraction during micturition. It helps squeeze the muscles even more because it squeezes on the outside. So it allows for urination. Okay. Now, the bladder histology will also, this is where we're going to discuss when the transition epithelium becomes or transitions into non-transitional epithelium, not non-transitional, but like flat, it turns flat. Normally, your transitional epithelium would be dome-shaped because it wants to allow the bladder to distend and, just have all this urine stored. And so when your bladder is full of urine and it's distended, these dome-shaped epithelial cells that we talked about, they would transition and become squamous. So they're not dome-shaped anymore. They're not cubit-like epithelium. They become more like squamous epithelium because they transition. And the mucosa, it's, as we said, transitional epithelium and it's lamina propria. It has 2 layers. And it moves from dome-shaped to squamous. And during the lower urine volume, when you don't have a lot of urine, the surface transitional epithelial cells, they're dome-shaped. That's kind of everything that we discussed. Okay. Now, can you guys please answer? Oh my God, wait, this has the answer. Okay, let's pretend that this is not here. I'm just gonna answer this since the answer is already here. But we want to indicate, we want to name the indicated structure. This is the urinary bladder, obviously, and the 2 organs that would be posterior to it in females are the uterus and the rectum. Now, sorry. Okay, can you guys answer this one? This one doesn't have the answer. Yes, you're right. But what is the name of the muscle? Yes, exactly. Good job. Okay. Give you guys like 10 more seconds to answer. Okay. Good job. So this is your rugae or the transition epithelium, you're right. It's basically the same thing. The mucosa just forms these rugae, but if it's directly asking what this is, just answer rugae. Your answers are correct, but this is more accurate. Now, layer 2 over here is the detrusor muscle or the muscularis muscle, muscularis layer of the bladder, but more specifically, it's the detrusor muscle. Now, we're going to be covering the urethra. Now, the urethra, it is what's responsible for moving your urine outside of the bladder. So the male urethra and the female urethra are actually very different. So the male urethra is much longer because it has to span across the entire shaft, the penile shaft. So it's from 15 to 20 centimeters, whereas in the female urethra, it just has to go through the cervix and the vagina. So it's just, 4 centimeters. The males have a longer and they have a much more complex urethra compared to the females, and they are longer and have variations in their width because we'll go over it in a second. Whereas the ones in the females, they are shorter and they're closer to the anus, which allows them to be more recurrent, to have more recurrent urinary tract infections. Since the urethra is much shorter, the bacteria can easily, or whatever microorganisms, they can easily infect and go to the bladder and the surrounding structures because the urethra is very short, so it has an easy access and it's straight. It's not convoluted, or it's very short and straight. Now, the internal urethral sphincter in males, it's much more developed than the females, and it consists of an extra muscle for ejaculation. That's why it's much more complex, whereas in the external urethral sphincter, it's equally as strong in both males and females. There's no difference, but the main difference is in the internal urethral sphincter because they need to ejaculate. As you can see here, this is the female urethra, whereas this is the male urethra. The female urethra is very short, as you can see. This is the female urethra. It's very short, only 4 centimeters, where over here it can span from 50 to 20 centimeters. Okay, now the urethral sphincters, Basically, they are just constrictions that allow you to control the urine, the output of the urine. So the urethrosphincters, the urethra starts from the neck of the bladder, as we mentioned when we were discussing the bladder. The urethra starts from the neck of the bladder, and it has two sphincters. You have the internal urethrosphincter, which is supplied by the autonomic nerves. So since it's autonomic, sympathetic, you can't really control this one. It's autonomic, so you have no control over it. However, the external urethrosphincter, which is outside over here, which it's more towards the outside, it is supplied by the somatic nerves. So you actually have control over the sphincter. I'm sure you guys are already aware of this. Okay. The somatic nerve, the somatic nerve is the perineal branch of the padental nerve. I don't think you guys need to know this, just know that it's somatic and it's supplied by the perineal branch. Okay. Now, the parts of the male urethra. Okay, the parts of the male urethra. As we said, the males have a more complex urethra compared to the females. They're much longer and they have a variation in the width. It has four parts. You have the pre-prostatic urethra, you have the prostatic urethra, you have you have the membranous urethra, and then you have the spongy urethra. We're going to go through each one in a second. So pre-prostatic urethra is very simple. It's before the prostate, so nothing special about it. The prostatic urethra is the widest part of the urethra, and it contains these important openings. You guys need to know these. You have the prostatic utricle, which is over here, and you have the two ejaculatory duct openings, and then you also have the multiple prostatic duct openings, which open from the prostate. These are important to know. Now you have the membranous urethra. This is extremely important. The membranous urethra is the most narrow and delicate part of the urethra, and this is why it can easily be injured with pelvic fractures or during urinary catheterization. So they probably will ask you guys in the OSPE, what is the most parts of the urethra that would get damaged? Then you would answer membranous because it's narrow and delicate, so it can easily get damaged or punctured. Now, this is surrounded by the external urethrosphincter and the bulbourethral glands, which are over here. I don't know if you guys can see them. Wait. The bulbourethral glands over here, these glands, they sit at the level of the membranous urethra, but they don't open into the membranous urethra. They're just located at the same level. The membranous, the bulbourethral glands, they actually drain their fluid into the spongy urethra, not the membranous urethra, but they are located at the same level. The spongy urethra is the longest part of the urethra, and it has two dilations. It has the bulbar fossa, which is in the beginning over here of the spongy urethra over here. And then you have the navicular fossa, which is more towards the end. It's in the end of the spongy urethra. Now, Hanin will cover the histology part of the male urethra.
Okay, so now for the male urethra, as Malak said, the male urethra has different parts. It's just not one long tube. It has the prostatic urethra, which is the part that's inside the prostate. It has the membranous urethra, which is the most delicate part because it's the most narrowest part, and the spongy urethra. Yes, it's three regions. However, it's not one epithelium in all of them. And unfortunately, there are many different types of epitheliums in this one structure. It can either be transitional, it can be stratified columnar, stratified squamous that's non-keratinized, and then stratified squamous that's keratinized. I'll tell you exactly each epithelium is where. Follow along in this, okay? So this is the prostate. This yellow-orange thing is the prostate, and it's pointing to the prostatic urethra. The prostatic urethra, this one is the transitional epithelium. It's the last structure that you're going to find in it, transition epithelium. So again, this is the prostatic urethra, and it's the transition epithelium. That's done. Then we went to the membranous part. Membranous urethra. Okay. First thing, it's called stratified columnar. First thing, let's divide it. What do I mean by stratified? Meaning that it's not a single layer, because it can either be simple or stratified. Simple, يعني one layer. Stratified, meaning that multiple layers. And you can see that here, this is multiple layers. Okay, and then how do you know, is it squamous, columnar, or cuboidal? You look at the top layer here, the one that's in front of the lumen. And here what you can find the urine. Okay, so here you can see that this one looks like a columnar. It looks like long. So basically it's stratified columnar. It can either be called stratified columnar or pseudo-stratified columnar. Dr. Annie, I remember in our lab, the slide we had was the stratified columnar epithelium. However, if you wrote this or this, you'll get the mark. But usually write what we took in lab. So write stratified columnar epithelium. So again, the prosthetic here was the last part where you can see the transitional epithelium, and then the membranous is stratified columnar epithelium. Okay. Okay. After the membranous, you're gonna have the penile or sponge urethra. It's basically the same exact picture as the membranous urethra. It's stratified columnar or pseudo-stratified columnar epithelium. Lastly, you're gonna have the orifice, and this orifice is like divided into two parts. The first top part, which is يعني somewhere here, it's gonna be stratified squamous, non-keratinized. And then when it's خلاص at the end, يعني closer to the skin, it becomes keratinized. And it's stratified squamous. So the previous ones were stratified, however, were columnar. 1 minute, sorry. Yeah. The previous ones were stratified columnar. The external urethral orifice is stratified squamous, and then it can either be non-keratinized or keratinized. Keratinized when it's closer to the skin. Okay, and that's everything about the male urethra. Let's just have a quick summary. We said here, which is going to be the prostatic urethra, what you're going to see, the last part where there is the transition urethra, transition epithelium. And then this is the membranous. You're going to find the stratified columnar epithelium. Same thing with the penile part. And lastly, which is going to be the external orifice, it's going to be the stratified squamous, non-keratinized epithelium. Something else that I have to mention, this one, we said it's the epithelium. What do you think this is? We said mucosa is made from two things, the epithelium and something. What is this? Perfect. Yes, it's the lamina propria. Perfect. It's the lamina propria. Now this is the male urethra. Now we're going to talk about the female urethra. For the female urethra, it has one lesion. It does not have the prosthetics so on because there's no prostate and so on. The female urethra is only one part. However, it still has those four different epitheliums, which are the transitional, stratified columnar, stratified squamous non-keratinized, and stratified squamous keratinized. Okay. So this is the female urethra part. We're going to start, we said there are always three layers. Mucosa, which is basically the epithelium and the lamina propria, and then the muscularis, which is the muscle part, and then lastly the adventitia. Let's start with the mucosa. The first part of the urethra is going to be transitional epithelium. And then the middle part of this urethra, so we can see like this part here is going to be the transition epithelium. And then a little lower is going to be the stratified columnar epithelium. And we said the mucosa is basically epithelium and lamina propria. And what's the lamina propria? Fibroelastic connective tissue. And then exactly like males, the external urethral orifice is going to be the stratified squamous, non-keratinized, and then at the end, when it's closer to the skin, it's going to gain keratin, and it becomes stratified squamous keratinized. I did not put histological pictures here because this was not mentioned in the lab, and any histology picture that will come in the lab will 100% be that you took it in lab. So if it's not covered in lab, then you don't have to know it. Okay, so we finished the mucosa. Now we're going to talk about the muscularis layer. It has two muscles, the inner longitudinal smooth muscle and outer circular. And lastly, the adventitia, which is just connective tissue. Okay, now pop quiz. They're telling you that this is the penile urethra. They're asking you what's A and what's B. And when performing what medical operation should a doctor be wearing of the membranous urethra? Like what operation? And I think Malak mentioned this. And the first question is what's A and what's B? Okay, perfect. Okay, can you also answer this question? Perfect. Okay, so A, second. A is basically the stratified columnar epithelium. And the previous question, which they asked you about the membranous urethra, it's the catheterization. With that, we're done with the urethra.
We're gonna take a 10-minute break now, and then we'll continue, inshallah.
Okay, so the next structure is the prostate. Okay, so the prostate is basically a small walnut-shaped gland that's found in the male reproductive system, and it's just below the bladder. So this is the bladder, and this is the prostate. It looks like a walnut, and it's only in the male reproductive system. And what's the function of this prostate? It produces the prostatic fluid. It helps in ejaculation, and those two roles will help in the reproduction process. So again, this is the bladder, this is the prostate, and it's a walnut shape. Okay, very, very important, very, very high yield are the zones and lobes. Lobes are not very high yield, but the zones are really important. So, first thing, we're going to talk about the transitional zone. Okay, looking at it like this, okay, I hope you did not read. This transitional zone, what does it surround? Like, what structure does it surround? What structure does the transitional zone, which is the green here, surround? Okay. I'll wait for more. Perfect. Yep. It surrounds the urethra. So this transitional zone surrounds the urethra. And what's the importance of that? That this is the common site for benign prostatic hyperplasia. This is very important. They might ask you, they give you a case, and you get from the case that this is benign prostatic hyperplasia. And then they're going to ask you, what zone does it affect in the prostate? It's going to affect the transitional zone. And what does it surround? It surrounds the urethra. So again, benign prostatic hyperplasia is in the transitional zone which surrounds the urethra. Always when you forget in the exam, try to remember the picture. Try to remember it was green, it was surrounding the urethra, and this is the transitional zone. Okay, then you're gonna have the central zone, which is surrounding the ejaculatory duct. You have the seminal vesicles, and then from the seminal vesicles, you're gonna have those ejaculatory duct. And this zone that surrounds the ejaculatory duct is the central zone. We said the transitional surrounds the urethra, central zone surrounds the ejaculatory duct. And okay, lastly, the peripheral zone. This is the peripheral zone. It's the common site for prostate cancer. A mnemonic to memorize it, peripheral starts with a P, and then prostate cancer. So the peripheral zone is the prostate cancer. Okay. In the scenario that they can give you, they're going to tell you after they did the digital rectal examination, they found they either tell you it's either firm or hard. You have to know which one is for the benign prostatic hyperplasia and which one is for the cancer. Hard one, which is like if you touch this, it's like hard as this area. This is the prostatic cancer. Firm, like this area, is the benign prostatic hyperplasia. So it's very important. If they tell you it's firm, it's the benign prostatic hyperplasia. And what zone will it get affected if it's benign prostatic hyperplasia? What zone is the most common zone for benign prostatic hyperplasia? Perfect. Transitional zone. Transitional zone, benign prostatic hyperplasia, and we said they describe it as a firm. If they describe it as hard, it's prostatic cancer. And remember the mnemonic, prostatic cancer starts with a P, but that's the peripheral zone. Okay. We talked about the zones, now we have the lobes. They usually don't include the lobes, or like they don't usually use it, and they describe which one is they describe the like hypertrophy and the cancer using lobes. They usually describe using zones. However, I just put it for the completion sake. You're gonna have here, okay, so this is basically the ejaculatory duct, and this is the urethra. The one that's below the ejaculatory duct is the posterior lobe, and the one here in front of the urethra is the anterior lobe. In the middle, it's called median lobe. Okay, posterior lobe, prostate cancer, same mnemonic, P, posterior lobe, P, prostate cancer. And what was the zone? Peripheral zone. Median lobe, benign prostatic hyperplasia. And what was the zone? Transitional zone. Again, if they get you in the question, it's most probably the zones, but I put it just for the completion sake. Now the histology part. The histology part, we're going to talk about a young prostate, which is like a young male prostate, and an old prostate. So, young prostate, there is two parts you have to know. This one, which is basically the stroma. Any stroma will have collagen and smooth muscles. So this is made from collagen or smooth muscle. Now, this round circular thing is basically the secretory part. This is the gland, this is the secretory part of the prostate gland. And if you have a closer look in it, the type of epithelium will be pseudostratified columnar epithelium. So again, we said this is the fibromuscular stroma, and this is basically the secretory part of the prostate gland. And what's the epithelium lining this secretory part? It's the pseudostratified columnar epithelium. Now, the old prostate, how can you differentiate between them? There is something called corpora amylacea. I'm not sure if I said that correctly, but it's corpora amylacea. How do you know that this is an old prostate? If you can see those concentric circles that are found in the secretory gland. So that if you see those big circles in the secretory gland, it's basically the old prostate. And usually a question comes, they're going to give you like two different, the young one or the old one, and they're going to ask you which one is the old, which one is the young, and why. And I think I put a pop quiz on that. But first, let's answer this question. There's a picture, but read the question first. A 60-year-old male presented with history of difficulty in passing urine since few weeks. On rectal examination, his prostate gland was enlarged and firm. Inconsistency. Which zone of the prostate gland marked A, B, and C is consistent with this finding? Okay, before I show the picture, I'll just like summarize the case. They're saying in the rectal examination, the prostate gland was enlarged and it's firm inconsistency. Okay, which zone is it? A, B, or C? Okay, some people are saying C, or some people are saying A. Think about it again. Let me show you the question again. It's saying that it's enlarged, firm, difficulty in passing urine. And what structure is it surrounding, or what structure is it is getting complicated? 1 second, let me go. Okay. Let me, okay. Okay. I'll give you the answer. The answer is A, and I'll explain why. Okay, let me go back. First thing, this is the urethra, and this is the urethra. The part that's surrounding the urethra, we said what zone is the one that's going to be surrounding the urethra? What zone surrounds the urethra? Transitional zone. And we said transitional zone is the most common area of benign prostatic hyperplasia. And the question asked us that it's a firm, and we said firm is the benign prostatic hyperplasia. So benign prostatic hyperplasia, which is in the most commonly in the transitional zone, and the transitional zone surrounds the urethra. We said which zone surrounded the ejaculatory duct? It was the central. And this one is the peripheral zone for the person that asked. B is the peripheral zone. Firm is the benign prostatic hyperplasia. If they said hard, it's prostatic cancer. So hard is prostatic cancer, and firm, like this one, is the benign prostatic hyperplasia. And if hard, if like touch this area, if it's hard like this, it's the prostatic cancer. Okay, the next question. Which one is the old prostate and why? Okay, whenever you're writing the answer, make sure that you write exactly as what the question asks you. So if they're telling you which one is the old prostate and why, and you just mention which one is the old prostate, then you will lose the mark because you did not explain why. Okay, yes, everyone is getting it correct. It's this one, which is the right one. Why? Because the corpora amylacea. Yes, which is going to be found in the secretory gland. Okay, we're done with the prostate. Now, the ultrasound and radiology. Okay, some basics before we start, because, okay, let me look at the ultrasound first. You can see that there's different colors. Some are gray, some are darker, some are black, and so on. Okay, so first thing, if it's completely black, it's called anechoic, and it usually represents the fluid. So fluid on ultrasound, it will appear black, and it's called anechoic. The bone will appear white. It's called hyperechoic. And soft tissues will appear gray. So again, all fluid will appear black, which is going to be anechoic, and then the bone is going to appear white, hyperechoic. Soft tissue is going to appear hypoechoic, which is going to be like between the black and the white, so gray. Okay. In the exam, they're going to get you the same exact ultrasound, or at least in our version, I also looked at previous finals, they give you the exact same thing and you have to label it. Let's start labeling. The outer layer, which is number 1, is the cortex. And then number 2 is the column. And Malak explained what's the column and what's the pyramid. So column basically separates between those medullary pyramids. The third one is the medullary pyramid, which is anechoic. Anechoic, look at it. It looks completely black. Black is anechoic. And then 4 here is the renal pelvis or sinus fat. If they point on number 4, say both of them, renal pelvis / sinus fat. So again, number 1 is going to be the cortex, 2 is going to be the column, 3 is the pyramid, and here this is the renal pelvis or sinus fat. Okay, for the next section, I'll be giving you pictures, and you should spot the abnormality in the pictures. Okay, this first picture, where do you think, what's the abnormality? What do you think? Okay, be specific. Okay, yes, it says a calculi, but where is this calculi? Perfect, perfect, perfect. Yes, and the person that said left kidney, perfect. Because you always have to say the right or left, because you can't just tell them there is a calculus in the kidney. But which kidney is it? So you have to always specify. So basically this is kidney stone that's going to be found in the left lower pole. So this is it. This is going to be the kidney, and this one is the stone here. And it's in the left kidney, like you guys mentioned. Now this one. Perfect, perfect. MashaAllah, perfect. MashaAllah, guys, you're all ready, trust me. It's, yeah, the staghorn calculus in the left kidney. Why is it called staghorn? Because it resembles the staghorn. But it's not really OSPE, but I just have a question I want to ask you. What is like the mineral that forms this staghorn calculus? It was mentioned in, I remember it was mentioned in, I think, Dr. Vlad's lecture. Perfect. Yes, magnesium ammonium phosphate. I'm not sure if they're gonna ask you that in OSPE or not, but I just said that I should say it. Okay. Well, I already talked about these constrictions before. However, like just a quick recap, we have here the first constriction, which is basically between the pelvic and the ureter. It's called what? It's called the ureteropelvic. And here, this part is the pelvic, this is going to be the pelvic brim, the part where the common iliac bifurcates into internal and external. And lastly here, this is the uterovesical, which when it goes into the bladder. Okay. Okay, now I'll be describing those parts. We start with here, which is basically the minor calyx. And you definitely know the gross anatomy from the previous part. This is the minor calyx, and they all come joined together here in the major calyx. This is going to be the pelvis. And this part is going to be the ureter. Yeah, that's it. Again, this is going to be the major calyx. This is going to be the pelvis. This is the ureter. And I forgot to mention is it left or right. This is going to be the left ureter. This is going to be the right ureter. And okay. This is basically a bladder stone. If they get you a question, they'll basically just give you this image and tell you what is this. It's really low yield. I've never seen it before, but I put it just for the sake of completion. Now the urethrogram, which is very important. This part, number 1, is going to be the bladder. Urethrogram, it shows you the urethra and also the bladder from top. This is going to be the bladder. And then here, number 2 is going to be the prostatic urethra. And here, the part which is the narrowest part is going to be the membranous urethra. And if they ask you a question, it will most probably, they're going to point on number 3, and they're asking you, what's this part and what clinical condition or what significance of this part? Because they always love asking about the clinical significance, not just give me this, give me that. So third part here, this is going to be the membranous urethra. And this part is going to be the spongy and penile urethra. Here is going to be the bulbous urethra, and then here is the penile urethra. And this is the bladder neck. So again, a recap. This is the bladder. This is the bladder neck. This is the prostatic urethra. This is the membranous urethra, and then the bulbous urethra and the spongy or penile urethra. Lastly, it's the kidney, the arteries that supply, because the kidney, there's different poles in the kidney and like different segments. Dr. Elena, I think, mentioned it in one of her lectures, and this is so low yield. I've never seen it before, but I just, again, put it for the sake of completion. The arteries are, first one here, the one that's going to, on the top, number 1, you can see it's the uppermost, so it's going to be called apical, because apical is like the apex, the uppermost. Okay, and then if this is the apex, what's the number 5? It's the inferior. So this is the apical, and this is the inferior. And then you're going to have here the anterior, and this is going to be the anterior. The anterior is going to divide into superior and inferior. Number 3 is the superior, because if you look at it, it's like more like close than number 2. 2 is going to be the anterior, inferior, and 4 is most posterior. Again, I don't think this will come. However, I just put it for the sake of completion. Now, question time. They're telling you a nurse was trying to catheterize a male patient. During this procedure, urethra of the patient got damaged. Which of the following structure is most likely damaged? Exactly, and we stressed on this multiple times, and I'm 100% sure, inshallah, it will come. Ooh, easy marks. Yes, it's the B, because it's the membranous urethra. Okay, now the kidney. They're telling you what's X and what's Y, and where are the glomeruli found. Try now to link the anatomy part and so on. So what's X and what's Y? Okay. For the people that mentioned X as something, because I don't want to give the answer, there's 2 things. I said it can be either this or that, and you always say both. Okay. Perfect. I'll wait 20 more seconds. Answer B, guys. There's 2 parts, A and B. Don't forget. Okay. So the answers are, you're going to have the medullary pyramid. Wait, X. 1 second. Okay, wait, sorry. This one, if it's pointing here, it's basically the sinus or the renal pelvis, as you guys said. If it's pointing here in the dark area, it's going to be if it's pointing here at the dark area, it's going to be the medullary pyramid. And this is the cortex. And we said, where are the glomeruli located? Where are the glomeruli located? I know you guys did not take the histology part of it yet. When you take the histology part, you'll get this one, and we'll get back to it. The histology part is at the end. Okay, why? Yes, it's the capsule, but if they point more inside, it's going to be the cortex. Yes, okay. Yes, Y is mainly the capsule. However, if it's pointed more inside, it's going to be the cortex. And here, this is the This is going to be the renal pelvis or the sinus fat, and the darker areas, which is the anechoic, is going to be the medullary pyramid. Okay, now in this ureter, there is a calculus somewhere. Tell me what's the calculus and what are the corresponding vertebral dermatomes. I said the vertebral dermatomes back in the ureter part. I specified parts. Okay, I'll give you more 20 seconds. Try to remember what are the dermatomes. I got this question from a previous finals, but they do ask about the dermatomes. Yes, okay. It's the pelvic brim, and it's T11 to L2. It's here, it is, this one. This is the pelvic brim. The calculus is basically in the pelvic brim. And what are the levels? T11 and L2, to L2. And basically that's it for my part. Now sectional anatomy.
Hi guys. So we're almost done. We only have the sectional anatomy left, and then we're gonna go over the histology of the kidney. So the sectional anatomy is very easy. Honestly, this is mostly going to be you guys and your previous knowledge. So can you please label this and tell me the answer in the chat? We're almost done. We have a very few slides left. Name from 1 to 8. I'm gonna give you guys like 2 minutes. Does anyone want to unmute and try and answer this? Okay. No, you got it right the first time, actually. Do you guys just want me to give you the answer for these and then explain what each structure is there? Honestly, for sectional anatomy, it's just based on your previous knowledge and how you can correlate the different structures together. Okay. Mm-hmm. Yes, good job. You guys are very close. You're just missing one more that most of you are getting wrong. No, you don't really need the abdominal organs. The most important structures are the ones that are going to be surrounding your kidney. That's the most important thing that you need to know. Also, I got this from our drive, our labs, our sectional anatomy, because for you guys didn't really have any of this. So I'm not really sure if you covered it, but I do think it's important because we always get a question on sectional anatomy. And I think your lab committee just didn't cover it. So that's why I added this from ours. Just be the structures, honestly, they're just A structures. And just be very familiar with them in case you get asked on any of them. But most of the time, whenever I saw the past and whenever we got any questions on sexual anatomy, it would be the structures that are surrounding the kidneys. But do know all of them. It's only 8. And once you know, you just practice and test yourself on them multiple times. You just get very used to them and you know what each one is. You just want me to show you the answer now? Okay. So 1 is aorta. And then 2, you have the portal vein. A bunch of you guys said duodenum. It's actually the portal vein. You did get it right because it's coming straight from the liver. So it's the portal vein. And then over here are the right suprarenal gland and the left suprarenal gland. Now, when you're looking at sexual anatomy, you want to imagine that their feet, that they're laying down and their head is facing towards you, okay? So their left is your left and your right is their right. It's the same thing. Yani it's not like when we would normally look at an anatomical image and then switch it. It's the same thing because you're looking, this is from the feet. So this is why it's the same thing. Now, you have the right and left suprarenal glands. Now you're going to ask me, how are the suprarenal glands beside the kidney? Aren't they supposed to be on top of the kidneys? So how are they located here, like right beside them? It's because a little bit of, like, they go down a little bit. So the tip basically of the supraadrenal glands from the bottom, they would be hanging over the kidneys, and that's why you can see them over here. But if you do go up, you would see them on top of the kidneys as well. Now, you also have the left colic splenic flexure, which is number 5 over here. And then you have the stomach. I think just know everything on here. It's only 8, so be very familiar with them. You will 100% get a question on sexual anatomy in your OSPE, so be very, very familiar with the pictures. You might get anything, to be honest, but most probably they're going to be asking about the structures around the kidneys. Next, you have the right crest of the diaphragm. So over here, 7, you have the right crest of the diaphragm, and here is the left. Okay. Can anyone tell me whether this is a woman or a male, first thing, a female or a male, and label the... Okay, and why is it a female? Why are you guys so sure that it's a female? Are you sure that this is a uterus, though? Yes, and the green things are ureters. Good job. Okay, I'm gonna give you like 30 seconds. Okay, so you guys are right. This is very simple. You have your urinary bladder over here, and this is a woman because your uterus and the vagina, they would be located behind the bladder. Whereas in males, what would you have? Right behind the bladder. This is high yield. This is why I keep asking you guys about this. Okay, and what would be anterior to the bladder? Yes, pubic symphysis. Good job. Yes, exactly. In males, right behind the bladder would be the rectum, whereas in females, vagina and the uterus. Be very familiar with this because they will probably ask you a question about this. They will get to like a bladder and tell you like which structure is posterior to this. So be very familiar with it. Now, this is clearly a male because it says on top. I couldn't really cover that. But please Google each structure. I'll give you guys like a minute. Okay. All right, I'll show you guys the answers. Wait, let me go over. Yes. You can access the slide. I'll be uploading this, inshallah, on the drive, the Google Drive that you guys have for the PAL sessions. There's a drive for it, but I can send it to you after the PAL. Okay. Yes, good job, guys. You all got it correct, على فكرة. This is pretty simple. 32, you have your prostate, and here you have your prostatic urethra. Make sure in the exam that you mention that it's prostatic urethra and not just urethra, because it's located in the prostate. So obviously, it's prostatic urethra, and they're going to want you to specify. So make sure that you say prostatic urethra. And 30, which is right behind the bladder, the prostate, in behind the bladder and the prostate, it's the same thing, it's just below it. Right behind the bladder, you would have the rectum. So, okay, now I'm gonna cover kidney histology that we couldn't cover before. So the kidney, again, has two parts. You have the cortex, which is on the outside, and you have the medulla, which is in the middle, okay? So your cortex, it is made up of two things. You have the medullary rays, and the cortical labyrinth. So the medullary rays, from the name rays, so rays like sunshine, they're very straight, okay? Your cortical labyrinth, because they're a labyrinth, right? So they're a maze, and they're all like, just a labyrinth. Everything is within each other. It's a bunch of circles, okay? Now, how do you differentiate between whether you're in the cortex? Like, they would give you a zoomed-in histological image, and they would ask you, are you in the cortex or are you in the medulla? How would you be able to differentiate? You would look. And if you see corpuscles, then you're most probably in the cortex. I'll tell you what corpuscles are. But if you see corpuscles, then you're probably in the cortex, because they look like balloons. And if you can tell that you're more in the middle, then you're in the middle. Another thing that I want to mention is that in between the cortex and the medulla, you would have parallel tubules. They can be seen between the cortex and the medulla, and you can find some blood vessels in there. That's not really high yield. You don't really need to know this, but know that in the cortex, you would find medullary rays and cortical labyrinth. Now, your cortical labyrinth, you would find four things. Okay, you would find the renal corpuscle, looks like balloons, as Dr. Annie says. You would see proximal convoluted tubules, you would see distal convoluted tubules, and you would see macula densa. Now, macula densa is literally just distal convoluted tubules. It just goes back, and it acts as a feedback mechanism. I'm going to show you guys a picture in a second. But to identify each one, so your renal corpuscles, they're over here, the balloons. They look like balloons. They're very, very easy to identify. Let's just look at the picture from afar first. This is your cortical labyrinth, and this is your medullary ray. But you would see this picture, and you would see the balloon, and then you'd instantly think, okay, we are in the cortex, because I can see the balloons or the renal corpuscles. So I'm definitely in the cortex. So this is the cortical labyrinth. So you can see that everything is like a labyrinth, everything is in circles, whereas the medullary rays, everything is in rays, it's straight lines over here. They're very straight. Wait, whoops. Okay. They're very straight. Now we're gonna go back to the cortical labyrinth. The cortical labyrinth, as we said, you would see the proximal convoluted tubules. You would see first thing, renal corpuscles, which are balloons, and then you would see the proximal convoluted tubules, which are fuzzy pink circles. They're very visible. You can see here. These are all proximal convoluted tubules. Then you are going to see the distal convoluted tubules, which are also circles, but instead of it being pink and fuzzy, it looks more blue. It's fuzzy blue circles. So you can easily differentiate between this and the one that's right beside it, because this is much more blue, because the nuclei is much more prominent blue. Now, this is your macula densa. Now, you have something called the juxtaglomerulary. Okay, I can't even pronounce this. Juxtaglomerulary, whatever. Okay, juxtaglomerulary space, which is basically you have the. Sorry. Okay. Have the macula densa, and as we said, the macula densa is basically the distal convoluted tubule, but it just goes back. So the distal convoluted tubule will go back to the glomerulus, and it will basically facilitate the movement of ions and whatever from the distal convoluted tubule into the glomerulus. Okay, and this basically acts as a feedback mechanism for the renin-angiotensin system, and this is how it detects that something is wrong, and it needs to do something about it. So this is your distal convoluted tubule, and this is your macula densa, because how can you identify the macula densa? You would see, what's it called? A glomerulus, or, as you mentioned here, a renal corpuscle. Oops, sorry. Okay. You would see a renal corpuscle, and then you would see on top of it a distal convoluted tubule. And we said that we can identify the distal convoluted tubule because they are, blue and fuzzy. So distal convoluted tubule, and you have the juxtaglomerulus area, and then you have the macula densa. The macula densa is just a part of the distal convoluted tubule, but it acts as a feedback mechanism for the kidneys. Now, in the medullary array, you talked about the cortical labyrinth. The medullary array, you can see three things. You can see the straight proximal part. It's not convoluted, it's very straight. So you would see that part, and then you would see the straight distal part, also not convoluted, and you would see the collecting duct. Now, these three, you have the proximal pars recta. That's the fuzzy, it looks fuzzy pink, and it's over here. It's fuzzy pink, again, in lines. So if you see lines, you're probably in the medullary array area. So this is your proximal pars recta, and then the distal pars recta is also straight, but instead of it being pink and fuzzy, it's not fuzzy, and it has more nuclei. It looks more blue. So it's also straight lines, but not pink. So distal pars recta, and then you have the proximal pars recta, and then you have the cortical collecting duct, which is over here. It looks like a hole. It's just white and empty. It's the easiest one to identify. It's also a straight line, but instead of it being colored, it's just white and empty. Now, we're also going to discuss, now we talked about the cortex. We're going to be talking about the medulla and the collecting ducts. So the renal collecting duct system, how does it work? The urine, the flow of urine, as you can see here, I got this picture because I really liked it from Dr. Annie's slides. This is the collecting tubules, and then you would have the cortical collecting ducts, and then you would have the medullary collecting ducts, and then the papillary collecting ducts. It goes in order, and these are in the cortex, these are in the medulla, and these are in the papillary area, right? Okay. Now, okay, so this is kind of the same thing, but in the cortical collecting ducts, they are simple cuboid epithelium, and they're white. The medullary collecting ducts, they are taller, and they're more cuboid, taller cuboid cells, and they have the name principal cells. Over here, it's principal and intercalated cells. The principal cells are light, whereas the intercalated cells are dark. Then when you go into the calyx, the major calyx towards the papilla, you would see the simple columnar epithelium. Basically, the name is just principal cells. You wouldn't see intercalated cells here. It's just principal cells. So the only part where you would see intercalated cells would be in the cortical collecting duct. Now, we're going to be talking about the papilla, which is the tip part of the renal pyramid that we talked about, right? So the papillary collecting duct, you would have the papillary collecting duct of Bellini, and you would see the loop of Henle and vasa recta. So as you can see, this is the loop of Henle. It looks like a loop. It's kind of, this is a transverse section of it. That's why it's not a straight line. This is a transverse section of it, and this is why it looks like a circle instead of like a straight line. And here you would see the loop of Henle. It looks like a line because this is longitudinal instead of it being transverse. But it's the same thing, it's just thin. And then you would see the papillary collecting ducts of Bellini. They're very easy to identify because they're simple columnar epithelium, and they have short microvilli, but that's not really the characteristic feature. The characteristic feature is that they're simple columnar epithelium. They're very easy to identify. You have the loop of Henle, we already discussed that, and then the vasa recta. From the name vasa recta, so they have erythrocytes in them. And these are basically just endothelium. Okay. Here you have the same thing. So what are these? Actually, I would show you. I wanted to test you on this, but the answers are right there. Okay, we're just gonna mention this again. So number 4 would be your vasa recta, because you can see blood in them. It's just blood vessels. And then number 2, you would see the thin loop of Henle over here. This is a transverse section, whereas this is a longitudinal section. And then you have the papillary collecting ducts of Bellini. They're very obvious because they are simple columnar epithelium. And this is it. Can you guys answer these questions, please? Yeah, you guys answered this correctly, and I realized that I forgot to mention one thing in the first slide, but you did still get it correctly. So mashallah, you guys are prepared. Like what are you doing here? Mashallah. You guys are very prepared. Inshallah, you're gonna do great. Yes. Okay. So one is your macula densa. As I told you guys, when you would see a corpuscle and then you would see a distal convoluted tubule coming back, then and the two epithelium are touching each other. Dr. Annie used to say, "Mother coming back, no, baby come back to mama," and kissy kissy. So basically, they would come back here and they would touch the glomerulus. And B. Number one is podocytes. I forgot to mention this. Podocytes are just like cells that you'll find here. Just be very, very familiar with this picture because they usually always end up getting it. I saw it so many times in the past. And we got it in our OSPE exam as well. So make sure that you're very familiar with this picture. Can you guys label everything here for me? Yes. Yes. Yeah, you're right. It is. Okay. So I'm actually going to cover this because I realized that I didn't really concentrate on it. Oh, I actually forgot to put the picture, that's why. Okay, so basically here, okay, so two is the parietal. So here you would have the parietal simple squamous epithelium. Parietal is on the other side. Three is the Bowman space, and it's the space in between. One, as we said, it is the podocytes, and yeah, and then two is the parietal layer, and then this is the visceral layer, and then this is the parietal layer. Five, yes, you are right. It is the glomerular capillaries. Okay. Oops. Pretend you didn't see that. I need more answers. Okay. So the layer indicated by the red arrow over here, it would be your parietal epithelium, whereas the structure indicated by the blue arrow is the proximal convoluted tubule. Why is this a proximal convoluted tubule? Because, no, actually, I'm not going to say this. When they ask you guys a question, they will probably point towards this. They will ask you, what is this? And what is an identifying feature of it? Like, why did you decide that this was a proximal convoluted tubule? And a bunch of you answer this. It's because it's pink and fuzzy, and it has a lumen. So you are right. How would the distal convoluted tubules look like? Yes, dark bluish, more nuclei. Good job. And how would the papillary collecting ducts of Bellini look like? Yes, white lumen. And how would the vasorecta are very easy to identify. Why? Yes, because of the RBCs in the lumen. Okay. Hold on. Okay, want to go back to this because I realized that I did not put it in the slides for you guys. I'm going to put this in the slide on the drive, just to make sure, but I will cover this. Basically, again, these are the podocytes over here or the filtration slits. They would be found in Bowman's capsule. 2 is the simple squamous epithelium, and you would find it on the parietal side. 3 is Bowman's space, which is basically just a space in between the parietal and the visceral side. And then 4 is pars convoluta. It's over here, actually. It's not in this one. And then you would have the glomerular capillaries for that, for the person that asked. It is over here. Okay, be very familiar with this picture, please. It's very high yield. Now, before we end, Hanin wants to cover something real quick.
Okay, so just before the thank you slide, just I'll go back to the slide that the picture was missing in. I added it, just bear with us 1 second.
It's still not loading.
It says it's not loading, but I'll send it on the drive. You'll most probably find it.
Can you open it for me?
But 1 second, guys. Sorry, technical issues. I don't know what's wrong with the camera.
Yeah, I don't know why it's not. It's so slow. It was really slow today.
Okay.
They're asking, would you say that this palette is enough for the OSPE?
I would say it will cover high yield concepts, and we try to include as much as possible. However, go back to the lab material, because I don't want you to depend on this fully, and then they might get you something else. بس يعني for sure it covered all the high yield concepts inshallah.
Yes, inshallah. I covered almost all the high yield ones and the very repeated questions as well.
Yeah, and and all the questions we put for you guys were from previous finals.
Yeah, exactly.
So يعني we made sure that everything high yield is included.
Another recommendation real quick for histo. Honestly, all you need, like, you're not going to get histo pictures from the lectures in your OSPE. Just study the lab ones that Dr. Annie gave you, the lab book, and that's all you're going to need, inshallah. Also, her review sessions are so nice. She would not get anything out of those review videos. Most of the time, she never does. So they're very nice. Make sure you go over those for your actual final exam.
Okay, so the picture that did not want to load is basically this. Oh, it's in most probably in Dr. Atif's slides. It's just showing you guys. Okay, let's look at it. Here, the kidney stone. If this is here in this part, it's going to be from T10 to L1. And if it's here at the pelvic brim, it will be from T11 to L2. And if it's somewhere here, it's going to be at the pelvic ureter from L1 to L2. So basically, that's just the picture. But again, you'll find it when we send the slides, it will be updated, inshallah.
Inshallah. So,
and then lastly, one more thing before we end up is this question. Because now, since you took the histo part, the question will become easy, which was where are the glomerulus found? And they're basically found in the cortex. And wait, let me just go back to the. Okay, it was here. Where are the glomeruli found? They're basically found in the cortex. And with that,
We conclude.
we conclude.
Okay. Thank you guys so much for staying with us for the whole thing. Really appreciate you being here, and we hope this was helpful for you guys. We tried to cover everything, and hopefully, this will include everything you need for the OSPE. But please do make sure that you cover the actual lab material. And for Dr. Anna's review videos, I will add it as a link on the last slide when I upload it on the drive, so you can access it from there. But if you ask on your batch group, they will probably send it to you guys. And
Oh, lastly, just a couple of things. You'll find our numbers at the beginning. If you have any question, ask us. Oh, here's the feedback code. Please fill it in and let us know what we can do better. And it's not your last exam. You still have COM, but COM is easy, inshallah. This is your last exam of first semester. You all got this, inshallah. You'll all do great. And again, if you have any question, feel free to contact us.
please make sure you fill in the feedback form. They're so helpful for us so that we can know whether we should what we should improve in the future, because we want to give you guys the best quality. So please do make sure to scan this. Thank you so much, and have
Thank
a great
you.
rest of your day. Good luck on your exams.